Hello, I'm Akshay Desai. I'm a physician in the Advanced Heart Disease section of the Cardiovascular Division at Brigham Women's Hospital and Associate Professor of Medicine at Harvard Medical School. I'll be speaking to you this session on management of heart failure with reduced ejection fraction. These are my disclosures. We'll begin with a question. A 57-year-old obese man presents to the clinic for evaluation of shortness of breath. His past medical history is notable for type 2 diabetes, hypertension, and coronary heart disease with previous myocardial infarction treated with percutaneous intervention of the left anterior descending 2 years prior, as well as emphysema related to 60 pack years of prior smoking. On arrival, his blood pressure is 160 on 80 millimeters of mercury. His pulse is 90 beats per minute and irregular, and his jugular venous pressure is distended to the angle of the jaw. His lungs are clear and the extremities show 1+ pitting edema. His electrocardiogram reveals new atrial fibrillation. Which of the following diagnostic tests is likely to be most helpful in guiding his subsequent management? A, measurement of N-terminal proBNP. B, measurement of galectin-3. C, measurement of soluble ST2. D, a transthoracic echocardiogram. Or E, measurement of high sensitivity troponin T. The intended answer here is D, transthoracic echocardiogram, and this is an important beginning point because the patient clinically has evidence of heart failure with jugular venous distension and peripheral edema, as well as progressive symptoms of dyspnea. The issue is that his therapy is driven principally by his ejection fraction because there is variable therapy of patients with reduced versus preserved ejection fraction, as we'll show you. Those are the two cardinal phenotypes of patients with heart failure. Measurement of cardiac biomarkers, which are the other options that you're given, may be useful in prognostication, but really don't aid this patient in whom the diagnosis of heart failure is already clearly apparent. Before we get to specific management of heart failure with reduced ejection fraction, I think it's important to have some flavor for the differences in clinical pathology that leads to heart failure. On the left side of the slide, we have a paradigmatic patient with preserved EF heart failure with a small chamber size and significant concentric left ventricular hypertrophy. Here, the chamber size relative to the wall thickness is very small, such that the volume to mass ratio is actually diminished. And this is the pattern of concentric remodeling we often see in HFpEF. This, for example, is a patient with severe hypertrophic cardiomyopathy. This is a normal heart for comparison with a normal or slightly larger LV chamber, lesser wall thickness. And here, for comparison, is a patient with reduced ejection fraction heart failure and a pattern of eccentric remodeling where the chamber size is markedly dilated relative to the wall thickness. And even though the LV mass is increased, the volume to mass ratio is increased. These are scanning electron micrographs and the three conditions for the comparison. If we look at the distribution of ejection fraction in patients patients hospitalized with heart failure, this is the pattern we see from the ADHERE registry. You can see that 40% or so of patients present with heart failure in the setting of a reduced ejection fraction. Another 40% present in the setting of a preserved ejection fraction, that is more than 50%. And then there's a group of patients that are increasingly recognized to be a possible distinct third entity who have a middling EF in the range of 40 to 50%. On the whole, patients with preserved EF compared to those with low ejection fraction tend to be older, are more likely to be women, and more commonly have a history of hypertension and chronic kidney disease, although the prevalence of coronary disease in this population, although it's still high, is a little bit less than in this group, which comprises the bulk of patients with prior myocardial infarction. If we focus on patients with heart failure and reduced ejection fraction, these are the distribution of common etiologies. About 11% develop heart failure and reduced EF in the setting of hypertension, another 10 to 12% in the setting of valvular heart disease, and about 40%, the bulk of patients, have some form of ischemic heart disease, often with prior myocardial infarction leading to ventricular dysfunction. The balance of patients with low ejection fraction heart failure or heart failure with reduced EF or HFrEF as it's come to be called have dilated cardiomyopathy. that is non-ischemic and may be related to any of a number of specific etiologies, or could, as it is in about half the cases, be still idiopathic. These specific etiologies of non-ischemic cardiomyopathy are worth keeping in mind as part of your differential, including increasingly important chemotherapy-related cardiomyopathies, with adriamycin being the paradigmatic agent, but newer agents like Herceptin and selected tyrosine kinase inhibitors like sorafenib or sunitinib being important. HIV disease, peripartum disease, other toxic exposures, including importantly heavy alcohol consumption or use of drugs of abuse like cocaine or methamphetamine, inflammatory or infectious disorders like myocarditis, including both lymphocytic myocarditis or giant cell myocarditis, or even hypersensitivity myocarditis that may be eosinophilic related to prior drug exposures. And then specific important etiologies are the tachycardia-related cardiomyopathy, which could be reversed with treatment of arrhythmias like atrial fibrillation, congenital heart anomalies, which can be associated with ventricular dysfunction, Chagas disease in patients from Chagas endemic areas where it is an important cause of cardiomyopathy like Brazil, and then stress-related cardiomyopathy, which is a particular entity. Some call it Takotsubo cardiomyopathy, where ventricular dysfunction has a particular pattern of often apical ballooning that is reversible and often provoked in the setting of stress. What we're increasingly recognizing is that of this group that doesn't have a specific discernible etiology of non-ischemic cardiomyopathy, about half likely have some genetic mutation that may contribute to the development. And so about 40% of patients with a previously thought to be idiopathic cardiomyopathy probably have inherited it. With these etiologies in mind, this is the generally recommended workup of patients with newly diagnosed heart failure, particularly in the setting of reduced ejection fraction. Patients should all get a history, including a 3-generation family history, to ascertain clues about a possible genetic contributor. Patients should have a detailed physical examination focusing on the full body, but particularly on the heart and lungs, as well as the abdomen. And an electrocardiogram may provide clues about the etiology, particularly ischemic heart disease or tachycardia. Echocardiography is critically important, not simply to differentiate low from preserved ejection fraction, but also to assess prognostic features, including the severity of mitral and tricuspid regurgitation, as well as right ventricular function, to assess LV chamber dimensions, which may speak to chronicity, since larger dimensions indicate longer standing disease, and also to provide clues as to the potential etiology, since wall motion abnormalities that are segmental may imply underlying ischemic heart disease. Laboratory values are often sent in the setting of newly diagnosed heart failure to ascertain particular etiologies, including thyroid disease, iron overload syndromes, and also to provide data that may help guide selection of appropriate therapies, including sodium, potassium, and creatinine. These may also have prognostic value. The trouble is that in general, the laboratory battery that's sent often doesn't illuminate a specific etiology for heart failure. Exercise testing or functional capacity assessment of some sort is critically important for all newly diagnosed patients with heart failure after optimization, because there's a quite tight correlation, as we'll see, between prognosis and functional capacity, much as there is in other disorders. In general, if patients have low ejection fraction heart failure or even preserved EF, some assessment for coronary disease in those at risk is critically important, because treatment of coronary artery disease is one of the few potentially reversible causes of left ventricular dysfunction, and unattended coronary disease, particularly if it's severe, may contribute to accelerated heart failure progression. There are a few tests that are not relevant for every patient with heart failure, but things to consider in the appropriate clinical scenario or measurement of plasma metanephrines to look for things like pheochromocytoma, use of B-type natriuretic peptide or N-terminal proBNP to assess prognosis and help assess the need for dose titration of medical therapies. Coronary angiography may be appropriate for many patients in whom ischemic heart disease is suspected, and may also give you information about hemodynamics that may further bear on prognosis. Cardiac MRI is not listed on the slide, but is another increasingly relevant consideration in many patients, particularly when infiltrative disease or inflammatory disease is suspected, since MRI may help to illuminate myocarditis or specific pathologies like cardiac amyloid iron overload syndrome such as hemochromatosis, or other pathologies such as prior myocardial infarction. Endomyocardial biopsy is increasingly reserved for those patients who have suggestive pathology by MRI or those who have rapidly progressive heart failure where urgent diagnosis may alter management, or where there's a suspicion for infiltrative heart disease such as amyloid, sarcoid, hemochromatosis, endomyocardial fibrosis, where the diagnosis may alter the approach to therapy. We now stage heart failure much as we stage cancer, and the staging begins, as per the professional societies, with patients who are at risk for heart failure but don't yet have structural heart disease. These are patients with diabetes, hypertension, or other risk factors, emphasizing that heart failure begins with prevention. Structural heart disease, once it develops, valvular disease, coronary artery disease, even in the absence of symptom, is considered stage B. These patients are treated with the goal of preventing onset of heart failure symptoms, and again, prevention is the emphasis in this group. Stage C patients are those that we would commonly recognize as having heart failure. These are patients who not only have structural heart disease or cardiac remodeling associated with symptoms, but also congestion and volume overload. And these patients are often further classified by the New York Heart Association functional classification, depending on their severity of functional limitation. With patients with class 1 disease having no functional limits, they could be stage B disease, or those with stage C. Those with having mild limitation being class 2, those with marked limitation being class 3, and those who are limited at rest or with minimal activity being class 4. Once you move down the ACC-HH stages, you don't move backwards, but you can move up and down the New York Heart Association functional class depending on therapy. New York Heart Association functional classification, as it worsens, is also associating with worsening quality of life. Stage D patients are those with refractory heart failure and are principally the province of advanced heart disease centers where there is consideration of advanced therapy options such as mechanical circulatory support, cardiac transplantation, or palliative options, including home inotropic support or palliative care in hospice. In general, functional class, whether it's defined by that New York Heart Association classification or more objectively by any of a number of functional tests, such as a 6-minute walk, a cardiopulmonary exercise test to measure peak oxygen consumption, or even exercise hemodynamics in the cath lab, are an important correlate of prognosis. Even with crude measures, but even more so with more objective measures, there seems to be a tight correlation between the severity of functional limitation and not only quality of life, as I mentioned, but also mortality, such that the patients with heart failure who have the worst symptoms and the most functional limitation, with cut points defined on this slide, being those who have the worst prognosis. And so increasingly, selection of therapy for patients with heart failure and reduced ejection fraction is keyed not only by the ejection fraction, but also by the functional capacity assessment. And this is data now replicated across a large range of clinical trials. For those patients in stage C heart failure, who will comprise the focus of my discussion for the rest of the talk, these are the goals. The goals are to address the precipitating factors of heart failure and to potentially identifying the underlying cause of heart disease, to initiate disease-modifying therapy to prevent progression and limit the risk of mortality. Typically, this is application of neurohormonal antagonists based on our understanding of the pathogenesis of heart failure, with reduced EF as proceeding from an initial cardiac insult that results in initially adaptive and then maladaptive sustained neurohormonal activation, with key targets being the sympathetic nervous system and the renin-angiotensin-aldosterone axis. Equally important to neurohormonal blockade is management of related risks that accrue with patients with heart failure and reduced ejection fraction, including the risks of sudden cardiac death and venous thromboembolism, and we'll attend to both of those as we talk about pharmacologic therapy. Another equally important goal is to improve patient symptoms as well as hemodynamics and end organ perfusion, and to do this we're principally focused on optimizing filling pressures and cardiac output with or without the assistance of invasive hemodynamic measurements. And then our goals are to also limit morbidity associated with the disease by keeping patients out of the hospital. And a lot of this relies not simply on the application of appropriate medical and device therapy, but also on patient education for self-management and longitudinal disease management, chiefly led by nurses who are educated about heart failure therapy. This is a schema of the stepped approach to pharmacologic therapy of patients with heart failure and reduced ejection fraction as of the most recent iteration of the cardiovascular guidelines. You can see that initial therapy of patients with congestion begins with application of diuretics, typically loop diuretics in order to relieve congestion. Thiazide diuretics are typically used to augment the effect of loop diuretics, but are rarely used in isolation. If patients don't have congestion, or once congestion is relieved, and if the ejection fraction is less than or equal to 40%, independent of New York Heart Association functional capacity, there is generally now agreed to be a role for ACE inhibitors and ARBs. We'll speak about this separately, about this class of new drugs called ARNIs, or angiotensin receptor neprilysin inhibitors. Principally, though, the approach, particularly in the less symptomatic patients, is angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Examples are given here. And beta blockers, specifically these three drugs which have been studied in clinical trials. For those who remain asymptomatic despite this foundational therapy, application of the next drug is important, and typically that is a mineralocorticoid receptor antagonist such as spironolactone or eplerenone, and we'll review the data for that and the considerations. And then if patients remain symptomatic, addition of other drugs including ivabradine, the combination of hydralazine and isosorbide dinitrate, and rarely digoxin, which has become now third-line therapy for heart failure, are still relevant. So an increasing range of pharmacologic options for management of heart failure with reduced EF that is carefully scripted by guidelines and is applied in stepped fashion to reduce morbidity and mortality. And we'll walk through the evidence base and the selection of patients for each of these therapies in the next several slides. Let's begin a little bit with use of diuretics for patients with heart failure. These are important things to keep in mind as you study for your board examinations. There are four broad classes of diuretics that are used in medicine. Carbonic anhydrase inhibitors such as acetazolamide are rarely used in heart failure, principally because they have minimal effect on the filtered sodium load, as they act principally in the proximal tubule, and in any sodium that is released in the proximal tubule is often reabsorbed by the time the ascending loop of Henle and the distal tubule are reached. Loop diuretics are the mainstay of therapy in patients with heart failure, and there are three in common utilization in practice. The one that's not listed here is ethacrynic acid, which is used rarely in patients with severe sulfa allergy, but is associated with high risks of ototoxicity and is often difficult to access. So for practical purposes, these are the three diuretics that we're considering, with variations between the three being related principally to their oral bioavailability. Oral furosemide is highly variable in its oral bioavailability, while bumetanide and torsemide are highly bioavailable and are often preferred in patients with absorption issues. The reason loop diuretics are the mainstay of therapy is they have the most pronounced effect on the filtered sodium load because they act in the thick ascending loop of Henle, which is the principal point of sodium reabsorption. And by blocking that sodium-potassium 2-chloride transporter, they are potent in their effects on sodium excretion in the kidney. Thiazide diuretics act in the distal tubule. There are two paradigmatic agents, including hydrochlorothiazide and metolazone, with chlorothiazide being another option. Thiazide diuretics have a minimal effect in isolation, but can be used in combination with loop diuretics to dramatically increase the filtered sodium load. And together, these drugs are more potent than either in isolation. The challenge, of course, with combination diuretic therapy is potassium wasting, and the use of thiazides in combination with loop diuretics should be accompanied by careful monitoring for hypokalemia. Potassium-sparing diuretics are a special category. Epithelial sodium channel inhibitors like amiloride are used rarely in heart failure patients because there's no evidence of improvement in morbidity or mortality, but they might be used for potassium-sparing effects. But more commonly, because of the other evidence that we'll review and their effects on morbidity and mortality, aldosterone receptor antagonists are utilized not only to conserve potassium, but also to improve remodeling. They're not typically used for sodium excretion enhancement, although they do have some of that effect, particularly when given in combination with loop diuretics. A few notes about pharmacodynamics of loop diuretics. This is a sigmoidal dose response curve that is typical of loop diuretics. And on the y-axis here, we have the sodium excretion rate related to the amount of loop diuretic that's given to the tubule. And you can see that there is a flat portion of the curve at which there is minimal increase in sodium excretion until one reaches a threshold dose, and a relatively linear dose response up to a ceiling. And then beyond that, additional diuretics don't provide additional effects on sodium excretion. The implications of this are that one needs to use an adequate initial dose and avoid overdosing, since at that dosing below the threshold will result in no response, and dosing above the ceiling will provide no additional response. Other things to keep in mind are that this dose response curve is right shifted in patients with heart failure, such that the threshold for an initial response to loop diuretics is increased, and the dose response is less steep over the range of doses, and the peak effect is seen at a lower overall dose. A few notes and pearls for consideration in your patients with heart failure are that if you're not getting a response to once daily therapy, consider more frequent administration of effective doses to maintain an adequate trough concentration. And then also consider combination therapy for diuretic resistance, as mentioned, being mindful of the risks of hypokalemia with thiazides and loops in combination. Let's shift gears and move from diuretic management of congestion to treatment of neurohormonal balance. Neurohormonal imbalance rather, and I think in general, as mentioned, heart failure is increasingly understood as the consequence of deleterious sustained neurohormonal activation, particularly when it occurs in the setting of reduced ejection fraction. And the notion here is that low ejection fraction or diminished cardiac output stimulate the activation of the renin-angiotensin system and the sympathetic nervous system. These are in an effort to conserve blood pressure and maintain blood flow to the center. Initially, this response is helpful, but when it's sustained indefinitely over time, it is maladaptive and has effects on progressive ventricular remodeling, enlargement, and the onset of heart failure and associated complications. Key metabolites that are of relevance here are angiotensin II, aldosterone, norepinephrine, vasopressin, and endothelin, and in general, these hormones alone or in combination promote vasoconstriction, fluid retention, fibrosis, and hypertrophy. What is less often recognized is that there are endogenous compensatory mediators that are elaborated during chronic activation of these systems, including the natriuretic peptide axis, nitric oxide, prostaglandins, and bradykinin. And these beneficial neurohormones, if you will, have counter-regulatory effects that promote vasodilation, diuresis, antifibrotic effects, and antihypertrophy to regress some of the remodeling that happens in the setting of sustained activation of the renin-angiotensin system and sympathetic nervous system. Based on this model, effective therapy of heart failure would involve interrupting these deleterious neurohormones and trying to augment expression of these hormones and restoring neurohormonal balance. And this indeed is the approach that we take to pharmacologic therapy of heart failure with reduced EF in 2018. To address the selection of pharmacologic therapy, let's work first through the renin-angiotensin-aldosterone axis. And remember that the key mediator here is angiotensin II, which is generated through conversion of angiotensin 1 from conversion of angiotensin 1 by angiotensin converting enzyme. ACE inhibitors interrupt this conversion, but also interrupt the breakdown of bradykinin to inactive fragments, and this may be one of the reasons they're associated with angioedema. One can also interrupt this cascade a little more proximally by inhibiting plasma renin, which is the rate-limiting step in angiotensin II generation. But even both of these steps really don't interrupt completely the production of angiotensin II, which can also be generated through non-angiotensin converting enzyme pathways like the kinase system. This is one of the reasons that we developed angiotensin receptor blockers as an alternate approach to angiotensin receptor inhibition. This has the advantage of avoiding the bradykinin-related effects of ACE inhibitors and may provide more complete suppression of angiotensin II because there is blockade here at the type 1 receptor rather than at the level of angiotensin converting enzymes. So there's the opportunity to block angiotensin II that's produced through non-ACE pathways. Stimulation of the AT1 receptor is important in the release of aldosterone from the adrenal gland. But there are other pathways for generation of aldosterone as well. And mineralocorticoid receptor activation by aldosterone is really responsible for a lot of the downstream adverse cardiovascular effects, and that step is inhibited by spironolactone, eplerenone, and other mineralocorticoid receptor antagonists. So there are at least 4 different paths to interrupt the renin-angiotensin system axis that are relevant to heart failure management. Let's start first with ACE inhibitors. ACE inhibitors in heart failure are the paradigmatic neurohormonal antagonist. They improve symptoms, clinical status, and exercise capacity, as well as cardiac function. They reduce hospitalizations and morbidity in patients with heart failure while improving functional capacity and reversing ventricular remodeling. They prolong survival and reduce vascular events even in stage B patients. The outcome trials of ACE inhibitors in heart failure are Protean, and these are just a synthesis of some of the key studies that are often cited. The important thing to recognize is not the specifics of the trials, but that the trials have enrolled patients across a wide variety of functional classes, ranging from the asymptomatic to the very severe, and including those with both non-ischemic and post-MI heart failure, which is probably a separate clinical entity. Overall, these trials, which have enrolled patients across a range of severity of illness, as you can see in the placebo mortality rates, have given all consistently the same message, which is a significant reduction in overall mortality of about 30% with application of ACE inhibitors compared with placebo. And it's these data that have led ACE inhibitors to become the primary therapy of choice for patients with low ejection fraction heart failure. What's been noted, as mentioned as we were discussing the system itself, is that ACE does not produce long-term suppression of angiotensin II because over time, patients treated with angiotensin-converting enzyme inhibitors do have escape by activation of those non-ACE-mediated pathways for angiotensin II production. As a result, suppression of angiotensin II may be incomplete during treatment with ACE inhibitors. And this might be better treated with blockade of angiotensin II at the receptor level. In addition, there are about 8 to 10% of patients who can't tolerate an ACE inhibitor, principally due to cough or angioedema, and those patients need an alternative. And this is the other rationale for consideration of angiotensin receptor blockers. There are now several trials of angiotensin receptor blockers in heart failure. Most of these, as you can see, or in fact all of them are active comparator trials, with the comparator being an ACE inhibitor, or in Valiant the combination of an ACE inhibitor and an angiotensin receptor blocker. And the message from all of these trials, which again have enrolled patients across a spectrum of disease severity, is that there is no difference in clinical outcomes with ACE inhibitors and ARBs in patients with heart failure or reduced ejection fraction. And the message is that in general, ARBs are excellent and proven alternatives to ACE inhibitors and should be considered if patients develop cough or other side effects. Realize that the risks of hyperkalemia and worsening renal function are likely similar with the two drugs, so those would not be reasons to switch classes. I mentioned that there is the opportunity to interrupt angiotensin II generation at the rate-limiting step, which is the step of renin. And there are commercially available plasma renin inhibitors, the principal agent being aliskiren. These are the data from the Atmosphere trial looking at aliskiren, enalapril, or the combination of aliskiren and enalapril in patients with chronic heart failure and reduced ejection fraction across a spectrum of symptom severity. The message from this principal results slide from that trial, looking at the primary endpoint of cardiovascular death or heart failure hospitalization, is that there is no difference between enalapril and the plasma renin inhibitor aliskiren with regard to prevention of outcomes, nor is there incremental benefit to the combination of a plasma renin inhibitor and an ACE inhibitor. The outcomes are the same in all three groups. And in the groups that received the combination of aliskiren and enalapril, there's a higher risk of hypotension, hyperkalemia, and worsening renal function. And aliskiren did not meet the non-inferiority bound with enalapril. So overall, the message is that aliskiren probably has no clinical role in the management of heart failure patients, and we should be sticking to patients with a selection of ACE inhibitors or ARBs. Optimal use of neurohormonal antagonists in heart failure is not just about prescription of the right drug classes, but also selection of the appropriate dose. And this is data from two separate trials of low versus high dose renin-angiotensin system inhibition making that point. The Atlas trial compared low versus high dose lisinopril, the HEAL trial low versus high dose losartan, and the message in both trials is that high dose wins. And the clinical practice translation of this is that that doses of the drug should be titrated to the doses achieved in clinical trials or to the guideline-directed dose, and that this should be deliberate and not triggered purely by the worsening of symptoms in clinic. Shifting gears, let's talk a bit about sympathetic nervous system inhibition with beta blockers. Decades of research reveal that beta blockers have a number of effects that are clinically important and may modulate the progression of heart failure. This was initially considered to be a contraindicated therapy in patients with reduced EF heart failure because of the negative inotropic effects. But since then, it's been recognized that long-term there is upregulation of beta receptors that can be promoted through administration of beta blockers that enhances sensitivity to catecholamines. There may be improved coupling of beta receptors to secondary intracellular signals, alterations in myocardial metabolism that are beneficial, enhanced calcium transport, inhibition of the renin-angiotensin system, and inhibition of other deleterious neurohormonal antagonists systems that may be beneficial. Although there is this negative inotropic effect in this study that's seen in early administration, over time the effect of beta blockers, here red in the slide compared to control in yellow, is to improve ejection fraction, and it's this observation that chronic effects differ from the acute hemodynamic effects that really was revolutionary and has led to the standard utilization of beta blockers as a second therapy for heart failure. This negative inotropic effect, however, is something to consider in patients who are acutely hospitalized with heart failure, since there may be the negative inotropic effect might be poorly tolerated, and in general, the beta blockers should be induced and introduced in the compensated state. As for ACE inhibitors and ARBs, there are a number of clinical trials of beta blockers that demonstrate benefit in symptomatic heart failure. There are a few nuances to the beta blocker story that are distinct, however, from the ACE-ARB story. The first is that not all beta blockers are alike. While we think about ACE inhibitors and ARBs as exhibiting a class effect, that means you can select any drug, beta blockers are distinct in their receptor selectivity, some being more beta-1 selective, others being mixed selectivity beta blockers. And that selectivity probably matters because in this case, bisoprolol, metoprolol succinate, and carvedilol trials have shown benefit, while trials of other drugs like bucindolol have not shown clinical benefit. The other message is that even with effective beta blockers, dose seems to matter. Yellow reflect the trials in which the beta blocker was given at higher dose. White reflect the trials in which the beta blocker was given at lower dose. And you can see that in general, the higher dose trials show greater statistical benefits. The consistent message is that if applied at adequate dose, beta blockers that are evidence-based, such as bisoprolol, metoprolol succinate, and carvedilol, all have about a 30% reduction in overall mortality across a range of heart failure severity, and this is the data that really supports consistent utilization in all patients with low ejection fraction heart failure. This is another statement of the variability across beta blocker classes, with the approved classes for use in low EF heart failure being circled. Here's some indication of the relative beta-1, beta-2 receptor selectivity, with bisoprolol being the most selective agent and metoprolol succinate close behind. Carvedilol has mixed selectivity with application with blockade of both the alpha and beta receptors, and so it may be a drug that's more useful in patients with higher blood pressure, whereas these drugs may be more useful in those with lung disease, where the off-target effects of beta-2 inhibition may be poorly tolerated due to bronchospasm. There is some data that suggests comparative differences between the efficacy of different beta blockers in heart failure. This is the trial that's often cited to support use of carvedilol over metoprolol succinate. However, remember that beta blockers were approved based on the efficacy seen in the MERIT-HF trial of metoprolol succinate, in which the mean dose was around 200 milligrams, which is a dose of metoprolol tartrate 100 milligrams twice daily. This is not what was compared in COMET, which compared patients with carvedilol 25 milligrams twice daily to metoprolol tartrate 50 milligrams twice daily, which is a relatively unfair comparison between a evidence-based and a subpar dose of beta blockers. Not surprisingly, in this high versus low dose comparison, there does seem to be a clinical benefit to carvedilol that is statistically relevant, and this has led some to promote use of carvedilol over metoprolol, but I think it's also important to recognize that this is not an evidence-based comparison in the comparator arm. Overall, however, there are subsets of patients where carvedilol might be preferred, including those with hypertension and diabetes, because there are some beneficial metabolic effects of carvedilol that might be exploited for that population. We're often asked, since both ACE inhibitors, ARBs, and beta blockers are important, which drug should one give first? And the guidelines now make a statement about this based on CBIS-3. This is a trial which randomized patients to different sequences of initiation of bisoprolol and enalapril. The bisoprolol first strategy in green was no different than the enalapril first strategy in yellow with regard to the outcomes of overall mortality or heart failure hospitalization. In this symptomatic low ejection fraction heart failure hospitalization, the message therefore is that both drugs are important. The sequence of initiation is not likely critical. A corollary to this question is it better to have low doses of two agents or high doses of one? And the message there seems to be that since most of the benefit is from the initial application of the drug and that there is lesser benefit from dose titration, it's probably a better strategy to try and get low doses of both ACE inhibitors and beta blockers on board and then work on dose titration of each category. We'll shift gears and talk about other strategies for renin-angiotensin system inhibition. The principal one to consider is the aldosterone antagonists or mineralocorticoid receptor antagonists. Use of mineralocorticoid receptor antagonists, including spironolactone and eplerenone, has now been explored in 3 separate trials of heart failure with reduced ejection fraction, enrolling patients across a spectrum of disease severity, including those with mildly symptomatic disease in the EMPhASIS-HF trial. These are largely class 2 patients. The message, again, is consistent across severe heart failure, mildly symptomatic heart failure, and post-MI heart failure, that application of MRAs on top of ACE inhibitors and beta blockers is associated with statistically important reductions in morbidity and mortality of upwards of 25 to 30%. The downside of use of aldosterone antagonists in patients with heart failure, many of whom have associated chronic kidney disease, is that these drugs do carry with them a risk of worsening renal function and hyperkalemia. And indeed, in these epidemiologic series following the publications of the data supporting use of aldosterone antagonists in heart failure, we saw a marked rise in the incidence of hospitalizations for hyperkalemia, and those two events may have been related because broad utilization of MRAs may have, particularly in patients who were outside the strict criteria used to enroll patients in the trial, may have resulted in a heightened risk of hyperkalemia. And this girds the need for careful monitoring of patients to avoid that risk. So the synthesis of use of aldosterone receptor antagonists is that once you've optimized the ACE inhibitor or ARB and the beta blocker, use of aldosterone antagonists should be considered in most patients with symptomatic heart failure and reduced ejection fraction. There is an obligation in these patients following initiation to monitor potassium and renal function, likely within a week of dose initiation or dose titration, with dose modification based on potassiums more than 5.5. The use of aldosterone and receptor antagonists or mineralocorticoid receptor antagonists should be avoided in patients who've had prior hyperkalemia or patients with advanced chronic kidney disease defined at an eGFR less than 30 or perhaps a creatinine more than 3 milligrams per deciliter. There should be caution, particularly close surveillance in those who are at high risk for hyperkalemia, such as those with diabetes or those who are elderly. And the combination of 3 drugs that affect potassium metabolism, such as an ACE inhibitor, an ARB, and spironolactone, should be avoided. There are 2 different options, including spironolactone and eplerenone. Eplerenone is a more specific inhibitor of the mineralocorticoid receptor and has less off-target effects. Spironolactone tends to inhibit androgen synthesis as well, and therefore is more likely to produce gynecomastia. Use of spironolactone and eplerenone are likely equivalent as long as the dosing is adequate, and generally in our practice we begin with spironolactone and switch to eplerenone if patients have side effects. Some prefer the use of eplerenone in patients with post-MI heart failure because that's the drug that was tested in the EMPhASIS clinical trial. There are other approaches to cardiac unloading, which is one of the mechanisms by which vasodilators have benefit. And alternate vasodilator strategies such as hydralazine and isosorbide dinitrate in combination still do have benefit in patients with low ejection fraction heart failure. This is data from the first vasodilator trial in heart failure called VEFT-1 compared to VEFT-2, which was the follow-on comparator between that primordial combination, hydralazine and isosorbide, against enalapril. You can see the curves overlaid here. In the VEFT-1 trial, the combination of hydralazine and isosorbide was far better than placebo with regard to reductions in overall mortality. But this combination was quickly supplanted by use of ACE inhibitors because ACE inhibitors resulted in incremental reductions in mortality. This data should be kept in mind when you have patients who don't tolerate ACE inhibitors or ARBs due to worsening renal function or hyperkalemia, or those in whom you're concerned about use of ACE inhibitors or ARBs because of the risk of hyperkalemia or worsening renal function, maybe those with advanced chronic kidney disease. And in those populations, the use of hydralazine and isosorbide may be an important alternative. The other circumstance in which this alternative should be considered are those African American patients with advanced symptoms of heart failure, class 3 and 4 patients. This is this population enrolled in the AHEF trial, where 1,050 self-described African American patients with heart failure and reduced ejection fraction in New York Heart Association class 3 or 4 were randomized to background medical therapy or background medical therapy according to guidelines augmented with the combination of hydralazine and isosorbide dinitrate dosed as listed on the slide. And the observation was that on the backdrop of pretty effective background therapy, including ACE inhibitors and beta blockers in most patients and about 40% on an MRA, that the addition of isosorbide dinitrate and hydralazine was associated with even greater improvements in overall survival. This is a statistically significant result. The downside of this approach is the incremental pill burden. This was 2 tablets 3 times a day on top of standard therapy. And adverse events were common, partly because of the potent combination vasodilator therapy that was given, including headache in about 40% and dizziness in 30% that led to a high rate of study drug discontinuation. So an important consideration in ACE intolerant patients or ARB intolerant patients, and also in African Americans with advanced symptoms despite standard medical therapy, being mindful of the pill burden and the risk for adverse events. Digoxin is an old drug for heart failure, and there was a time in which it was given to every patient with heart failure. Increasingly, digoxin has become third-line therapy for heart failure, and it's principally because at least 2 large trials conducted with digoxin therapy have not suggested improvements in survival. What is clear is that if one looks in the primary DIGE trial, although there was no impact on mortality, there was an impact on the burden of heart failure hospitalizations with digoxin. And in the RADIANCE trial, when digoxin was withdrawn, the rate of heart failure hospitalizations went up. So there is clearly an impact of this neurohormonal therapy on the burden of heart failure symptoms, and it's one of the reasons that we still consider utilization of digoxin in patients with advanced symptoms, particularly those that are refractory to other therapies, or those with right heart failure where we don't have a lot of specific therapy. What's key about digoxin is its narrow therapeutic window, and if digoxin levels exceed 1, there is evidence of harm, perhaps even greater risk in women than in men at even slightly lower levels. And this is one of the reasons that dosing of digoxin, which used to be quite aggressive, has become much less. The message is we typically start digoxin at a low dose and do not titrate the levels, but periodically do check levels, particularly in the setting of fluctuating renal function, to make sure that there's not a signal of levels that are creeping up that might create harm. But digoxin has now become late-line therapy for heart failure. There are a few other therapies that need to be considered in patients with cardiovascular disease in general, and statins are become one of the most important therapies for cardiovascular prevention. This is data that from a trial enrolling patients with ischemic cardiomyopathy and advanced heart failure symptoms. So these are all patients with coronary heart disease, randomized to therapy with a statin, rosuvastatin 20 milligrams or placebo. In this trial, there was no benefit to statin therapy, although there were fewer hospitalizations for heart failure management in the rosuvastatin arm. This may be because the burden of atherosclerotic events, which is what statins prevent in patients with advanced heart failure, is fairly low. But note that the rates of mortality in this population were still pretty high. So statins probably don't influence clinical outcomes in heart failure patients, but if there's a primary indication for statin therapy, it's reasonable to continue them. This then is, again, a statement of guideline-directed medical therapy circa 2013, including those drugs. And I mentioned to you that the menu of options has expanded. Previously, we were giving loop diuretics and then ACE and ARBs or beta blockers for everyone, adding MRAs, and then considering additional therapies that we've discussed as a next step. We now have a range of new therapies that are available for heart failure, and specifically we'll discuss two. Neprilysin inhibition has emerged as an important new therapeutic approach to heart failure with reduced ejection fraction. Neprilysin as an enzyme is responsible for the breakdown of a number of endogenous vasoactive peptides, chiefly the natriuretic peptides, which are important from facilitating vasodilation and natriuresis, and they're part of that compensatory mechanism that I mentioned earlier. Inhibition of neprilysin can potentiate the action of those beneficial peptides. Unfortunately, because angiotensin II is also a substrate for neprilysin, this is a pretty promiscuous enzyme, neprilysin inhibitors have to be co-administered with a blocker of the renin-angiotensin-aldosterone axis. The combination of a neprilysin inhibitor and an ACE inhibitor, omepatrolat, which was the first drug approach used to do this, was associated with unacceptably high rates of angioedema, particularly in the OCTAVE and the OVERTURE trials. And as a consequence of that angioedema signal, this ACE-neprilysin inhibitor combination never saw the FDA approval. There's now a second agent which tries to skirt that angioedema side effect by using an ARB in place of an ACE inhibitor. It's called sacubitril/valsartan, formerly LCZ696. This is the first-in-class approved angiotensin receptor neprilysin inhibitor. This is the chemical structure of the agent, which is a crystalline complex consisting of equimolar quantities of valsartan and sacubitril, which is the neprilysin inhibitor prodrug. At low pH in the stomach, this dissociates into the two active compounds, valsartan, which is an ARB, and sacubitril, which is rapidly metabolized to LBQ657, the active neprilysin inhibitor. This combination is then available for both inhibition of the renin-angiotensin system and for inhibition of neprilysin. The value of this composite angiotensin receptor and neprilysin inhibition was studied in the PARADIGM-HF trial, in which patients were randomized to treatment with sacubitril/valsartan versus enalapril after a run-in period designed to prove tolerability of both target drugs at target doses. About 10,521 patients were initially screened, of whom 8,399 survived both phases of the run-in period, to be randomized to sacubitril/valsartan 97/103 milligrams twice daily or enalapril 10 milligrams twice daily, which was the evidence-based dose of enalapril proven in the SOLVE trial. The principal finding, which was quite unexpected, was that sacubitril/valsartan compared with enalapril was associated with a marked reduction of 20% in the risk of cardiovascular death or heart failure hospitalization over the period of follow-up, with a highly significant result in a low number needed to treat of only 21 patients to prevent one event. This effect on cardiovascular death and heart failure hospitalization was seen equally in the individual components of the endpoint, and also strikingly in overall mortality, which was reduced 16% by treatment with enalapril or sacubitril/valsartan compared with enalapril. The absolute risk reduction here is just about 3%. Effects on mortality on cardiovascular death we're seeing comparably in reduction in the two key modes of cardiovascular death, including heart failure death and sudden death, both of which were reduced about 20% by application of sacubitril/valsartan. Put another way, use of sacubitril/valsartan in preference to an ACE inhibitor and ARB, which already reduced mortality by about 15% compared with placebo, results in an incremental 16% in reduction in mortality, or about a 30% reduction in imputed mortality relative to, 30% reduction in mortality relative to an imputed placebo, although there was no placebo in this trial. Another way of looking at this effect is to look at it actuarially, and using data from the trial, we've estimated that this correlates with about a 1.5 to 2 year increment in life expectancy with the substitution of sacubitril/valsartan for an ACE inhibitor or ARB. There is a signal of safety that comes for that benefit. And the principal safety signal with sacubitril/valsartan is hypotension, as expected by its mode of action, which is very potent vasodilation. The other risks are worsening renal function and hyperkalemia, although they occur less frequently with sacubitril/valsartan than enalapril. Cough is also not surprisingly less with the substitution of the ARB moiety for the ACE inhibitor. There was no increase in drug discontinuations for blood pressure-related events in the trial, but patients were carefully monitored. With regard to angioedema, there was a risk of angioedema seen with this drug, although no severe cases of angioedema were reported. There is, however, still guidance that surveillance for angioedema is important, since there were numerically more cases of angioedema in the sacubitril/valsartan arm of the trial than in those in the enalapril arm of the trial. The way this data has influenced the guidelines is as follows. There is now the message by the guidelines that this new class of angiotensin receptor neprilysin inhibitors is equivalent to an ACE inhibitor or ARB for use in conjunction with beta blockers and MRAs for patients with chronic heart failure to reduce morbidity and mortality, and in patients with chronic heart failure and reduced EF who are in class 2 or 3 and can tolerate an ACE inhibitor and ARB. The data from PARADIGM-HF now supports the rationale for replacement of the ACE inhibitor or ARB by an ARNI to further reduce morbidity and mortality. And this is really the revolutionary thing, which is these agents now are recommended to supplant what was formerly cornerstone therapy, at least in eligible patients. 2 key class 3 recommendations, which are should not do. ARNIs should not be administered in addition to an ACE inhibitor or within 36 hours of the last ACE inhibitor dose, so there needs to be a blanking interval. And then in general, patients who've had a history of angioedema for any reason should not be given an ARNI, so this is not a substitute for those who've developed ACE inhibitor-related angioedema. A second target for therapy that's emerged is heart rate, and we've known for a long time that in patients in sinus rhythm and with heart failure, that heart rate is a potent predictor of outcomes. These are data from the CHARM overall trial suggesting that those in the highest tertile of resting heart rate have the worst clinical outcomes compared to those with the lowest tertile, and these data hold whether patients are treated or not treated with a beta blocker. There are now drugs that reduce heart rate. Beta blockers are the paradigmatic agent, but do have auxiliary effects, including effects on remodeling and blood pressure. And so the question becomes whether targeted heart rate reduction would also achieve similar effects in patients with heart failure. So there is now a drug that is called ivabradine that inhibits the sinus node action potential by blocking the I sub F current. This results in targeted heart rate reductions without any effects on chronotropy or lusitropy, or without any effects on inotropy or lusitropy. So this drug is isolated reduction in heart rate in sinus rhythm. The use of this drug in patients with heart failure and reduced ejection fraction was explored in the SHIFT study, in which patients were randomized to therapy with ivabradine or placebo on top of guideline-directed medical therapy, including a beta blocker at the maximally tolerated dose, and this is a key caveat. All patients had heart failure and reduced EF, and patients were randomized to treatment with ivabradine or placebo and followed until the occurrence of cardiovascular death or heart failure hospitalization. In this trial, those allocated to ivabradine on top of standard therapy saw an 18% further reduction in the cardiovascular death or heart failure hospitalization, and this was very significant statistically. Based on these data, the guidelines have now been updated to suggest that ivabradine may be useful add-on therapy to further reduce heart failure hospitalization in those patients with low EF heart failure who are symptomatic and on guideline-directed medical therapy, including a beta blocker at the maximally tolerated dose, if they are in sinus rhythm, not in atrial fibrillation, and have a heart rate more than 70 at rest. Importantly, the benefits of ivabradine are seen best in patients with sinus rhythm at higher resting heart rates, and the important determinant of outcome is the composite reduction in heart rate that can be achieved with beta blockers and ivabradines in combination, with the target heart rate in low EF heart failure and sinus rhythm increasingly being rates less than 60 beats per minute. A question: 45-year-old woman with a prior history of breast cancer comes to your clinic for routine follow-up of presumed adriamycin-related cardiomyopathy. She reports no progressive symptoms but is short of breath when rushing up a flight of stairs. Her current medications include lisinopril 10 milligrams daily, furosemide 20 milligrams daily, carvedilol 6.25 milligrams twice daily. An echocardiogram confirms a low ejection fraction with LV cavity dilation and moderate MR. On examination, the blood pressure is 110 on 70, pulse is 85 beats per minute and regular venous pressure is normal, lungs are clear, there's no edema. Laboratories include a sodium of 140, creatinine of 0.7, and NT-proBNP of 1200. Which would you do, and which is most appropriate? A, continue the current management. B, titrate the furosemide to 40 milligrams daily. C, increase the carvedilol to 12.5 milligrams twice daily. D, add isosorbide mononitrate 30 milligrams daily. Or E, add ivabradine 5 milligrams twice daily. The intended answer here is to increase the carvedilol to 12.5 milligrams twice daily. This is a patient in sinus rhythm with adequate blood pressure who's on a suboptimal dose of a beta blocker and has a high resting heart rate at 85 beats per minute. Although addition of ivabradine is a consideration, the trials suggest and the guidelines indicate that the first step is to always titrate the beta blocker if that's an option, and add ivabradine only as a next step. Addition of diuretics to a patient who's not congested by exam is not appropriate despite the elevated NT-proBNP, and addition of nitrates has no impact on morbidity and mortality, so we should focus on adjustment of therapy that is there. Doing nothing in this patient is not a great option because there's room for further optimization of guideline-directed therapy, and that's increasingly a message in our therapy. We'll close with just a few notes about other therapies for heart failure. Heart failure management in patients with low EF is about more than just drugs. Preventing recurrent hospitalizations and worsening symptoms is critically related to self-care of patients and longitudinal management that includes dietary counseling, patient education, counseling regarding physical activity and the importance of medication adherence, as well as regular follow-up, both by phone and in clinic, typically supplemented by specialized heart failure nursing. There are also a range of non-pharmacologic therapies that are important to consider to modulate the related risks of sudden death and thromboembolism that we will discuss separately at another time. Briefly, there is the question of anticoagulation in patients with heart failure to prevent thromboembolism. There's no question that patients with heart failure and atrial fibrillation should be anticoagulated since all of them by definition have an elevated CHA2DS2 VASC score. However, those patients who are in sinus rhythm, there's less data about what to do. This is one trial of routine warfarin use in patients with low ejection fraction heart failure and sinus rhythm, suggesting no benefit over aspirin alone. But this was not because of lesser efficacy of warfarin than aspirin. It was because the benefits of warfarin, which included reductions in ischemic stroke and venous thromboembolism, were offset by the heightened risk of bleeding. There's an ongoing trial of low-dose rivaroxaban for this same purpose to see if the balance of risk and benefit can be better attained using low-dose rivaroxaban called COMMANDER-HF that is ongoing and will report out shortly. Device therapy is also a critical component of heart failure therapy for prevention both of sudden death and for also regression of the heart failure phenotype. In patients with low ejection fraction heart failure, defibrillators should be considered for secondary prevention of those who've had a prior cardiac arrest or symptomatic sustained ventricular arrhythmia. And then for primary prevention in patients who have low ejection fraction in an inducible VT, or those who have chronic low ejection fraction that doesn't recover with guideline-directed medical therapy. Those with advanced heart failure that is refractory to symptoms and guideline-directed medical therapy that have poor prognosis and aren't candidates for advanced therapies, especially those who aren't expected to survive a year, are not candidates for ICD therapy. Cardiac resynchronization therapy has emerged as an important additional device-based therapy for management of patients with low EF heart failure and left bundle branch block. The approach here is to restore synchronous ventricular contraction by synchronizing the timing of septal and posterolateral LV wall contraction. This has benefits not only in reducing presystolic mitral regurgitation and improving cardiac output acutely, but also in promoting reverse ventricular remodeling, since this dyssynchrony that exists in left bundle branch block seems to accelerate the progression of ventricular dysfunction. The benefits of cardiac resynchronization on morbidity and mortality in patients with heart failure and reduced EF are most pronounced in patients with low ejection fraction, left bundle branch block, and a wide QRS duration. They seem to accrue a lot less in trials like MADE-IT-CRT to those with right bundle branch block or nonspecific IVCD, and those with lesser degrees of QRS widening, certainly less than 120 milliseconds, doesn't see as much, 130 milliseconds rather, doesn't see as much benefit. So to summarize, There are a number of things to remember about management of heart failure with reduced ejection fraction. For all patients, heart failure is a clinical, not an EF or laboratory diagnosis, and should be made based on the presence of typical signs and symptoms. Natriuretic peptides may help to augment the diagnosis of heart failure when it's uncertain, but really don't replace the clinical assessment. ACE inhibitors and beta blockers remain the cornerstone of heart failure therapy and should be titrated carefully towards the goal doses that are demonstrated to improve outcomes in clinical trials. When ACE inhibitors are not tolerated, ARBs are useful alternatives unless the side effect limiting titration is hyperkalemia or worsening renal function, in which case hydralazine and Iserdil might be better vasodilator combinations to consider. Increasingly, based on the PARADIGM-HF data, it's important to consider substitution of an angiotensin receptor neprilysin inhibitor in patients who tolerate an ACE inhibitor ARB to further reduce morbidity and mortality related to heart failure. And this is now a class 1 indication. Beta blockers should not be started in acutely decompensated patients, but are important for the vast majority of patients with low ejection fraction heart failure, and probably should be titrated towards the goal dose as for ACE inhibitors and ARBs. Once you have an ACE inhibitor, ARB, or ARNI, and a beta blocker on board, aldosterone antagonists are increasingly the favored next-line therapy because of their incredible benefits with regard to prevention of morbidity and mortality. As mentioned, hydralazine and isosorbide are reasonable alternative vasodilators and should also be considered in those who are still symptomatic with heart failure after guideline-directed medical therapy is applied, especially in the African American population, which was enrolled in AHEFT. Digoxin and ivabradine are additional therapies to be considered to further reduce heart failure hospitalization. Ivabradine, particularly in those patients in sinus rhythm who have persistently high heart rates despite maximally tolerated beta blockers. We need to be careful about the narrow therapeutic window. Device therapy we discussed briefly, and it is appropriate both consideration of defibrillators and resynchronization for many patients with heart failure and low EF, as well as those with left bundle branch block. And heart failure with preserved EF is a topic that we'll consider more deliberately in other talks in this series.